Yes. So thank you everyone for joining this morning for this presentation. I think I've probably met most of you that are here over the course of this study that has been ongoing for the past year and a half or so. We were a little bit delayed with COVID, but I think by this week we're actually en route to completing the study that we're going to just talk about today. So I know that everyone personally has met with me and knows much about the study, but I wanted to show what the general picture of the study is and how we can use the information and why are we doing this more than just explaining what are the procedures in the study. So the study itself is called Comprehensive Assessment of Severely Affected Multiple Sclerosis, and it's performed by our Department of Neurology at the University of Buffalo, State University of New York, and we're located in Buffalo, New York. Interestingly about Buffalo, Buffalo is known as the hotspot of multiple sclerosis in the US. Western New York has approximately 2,500 MS patients itself, and a lot of history comes back in Buffalo in terms of multiple sclerosis, even starting from 1977, where Dr. Lawrence Jacobs was the first one to test the medication now known as interferon in 10 patients, and later on, 15 years later, that medication was actually one of the first medications approved for treatment of MS. So we have a lot of history of MS patients and also a lot of history of research, which we try to keep the legacy in Buffalo. So today I'm joined by two great people with me. Zachary Weinstock, he is an MD Ph.D. student at the School of Medicine at the University of Buffalo. And I have Taylor Wicks. She is a master candidate with the Buffalo Neuroimaging Analysis Center in the neuroscience department at the University of Buffalo. First of all, this study is not performed only by several people. There are actually a group of people, multiple groups behind the scenes that are actually working on this study in using all the information that we are collecting here. So I'm just the face of it, but there are a lot more important people behind me that are actually directing this as it goes. The most important part is that I am the clinical director of the Buffalo Neuroimaging Analysis Center, and we are a part of the Department of Neurology where we are strictly related to research and mostly MRI-based research and using images in terms of determine the amount of disability MS patients have and how can we measure that pathology on MRI. The second also important, very important aspect of our department is our CASA-MS Center. And this is where our clinicians are actually daily seeing MS patients, and we have approximately between 2,000 and 3,000 patients with neuroinflammatory diseases being seen every year. Moreover, we have the neuropsychology division at the UBMD Neurology, and this is led by Dr. Benedict. And here we specialize in how can we actually quantify and measure the cognitive functioning of our MS patients, and how can we put numbers on this cognitive functioning so we can use that as a baseline for future tracking of the cognitive performance, and how can we determine who is a cognitively declining rate, who is cognitively impaired, and how can we try to reverse that if possible. And lastly, we have the Department of Pharmaceutical Sciences. This is the School of Pharmacy at the University of Buffalo, and they're responsible for all this processing of blood that we're drawing for this study, where we're going to analyze aspects like the Epstein-Barr virus infection and how much of that is antibodies are in your bloodstream, some levels of serum neurofilament levels, which are also measures of neurodegeneration in the brain. And this is a picture of all the major PIs. You can see me there. Dr. Zivatinov is next to me. Dr. Weinstein-Goodman, Dr. Bianca Weinstein-Goodman is also there, the director of the MS clinic as well, joined by Dr. Benedict, Dr. Ramanatham, and Dr. Dwyer. So who we are as Buffalo Neuroimaging Analysis Center, as I said, we're a research part of the Department of Neurology, and we use innovative research techniques and mainly neuroinformatics and bioinformatics in terms of to use this great amount of data that we collect from our MS patients. We focus really on quantitative neuroimaging, trying to measure and quantify the pathology, rather than having some neurologist saying you have a moderate amount of lesions or you have a high amount of lesions. We actually want to put a volume in it with milliliters. We want to put a number to those lesions and how are they in terms of severity. We have different areas of interest from MRI techniques using AI, which is very popular in the 21st century. We measure the amount of brain atrophy or brain volume loss that patients might have. And also we are measuring different aspects like the accumulation of iron in the brain, which is linked with multiple sclerosis. And also we're trying to see how the brain actually communicates between each other and how these axons, these wires, are connected and potentially disconnected by lesions, and how can that affect the whole network of the brain that we know of. So here I have a very short video of who we are. I cannot find them.
BNAC is committed to addressing what people with MS are seeking, a cure.
The Buffalo Neuroimaging Analysis Center, or BNAC, has been involved over the last 20 years in the research and treatment of multiple sclerosis and other neurological diseases. Our primary research focus is to find the cure for MS. We have been involved in more than 80 clinical trials as a centralized core lab, have experience collaborating with over 450 centers around the world, located on 5 continents in more than 60 countries. BNAC has published over 500 scholarly articles in peer-reviewed journals and presented more than 200 platforms and 750 posters on international and national meetings. BNAC has participated in more than 40 million in research grants.
In 1981, MRI was first used to view the brain of a person with MS. Buffalo, known as having one of the highest prevalence of MS in US, was also one of the first centers to introduce MRI in the clinical use. Dr. Jacobs, a pioneer of MS therapeutics, supported the funding of Buffalo Neuroimaging Analysis Center.
BNAC back then was just a single office. Dr. Zavadinov joined us in 2003, and over the next decade grew it to be one of the top MRI centers in the world.
We've really evolved from a one-room center to an over 10,000 square foot research facility.
At this point, BNAC is in the unique position to tackle the most complex questions of neurological research from various angles. We now cover the complete translational spectrum from basic research to clinical implementation. Very few other places like this exist in the world.
For more information about BNAC research capabilities, educational opportunities, and clinical trial services, visit our website at www.bnac.net.
So that's our short spiel that we have for video for introduction of our center. Now we go to the actual important part, and that's the CASA-MS study. And really, what does CASA-MS study aims to answer? And it's a first-of-a-kind study that tries to explore the question that haunts many MS patients as soon as they are diagnosed and their first time come to the clinic. And these are questions that we hear all the time from newly diagnosed MS patients. And that's, am I going to be severely disabled by my disease? And what should I expect going forward? And unfortunately, today we have essentially no research whatsoever about the people with MS who are in advanced stages of the disease. There are no therapies for these people as we know of, and there are no best practices, or we have no guidelines. What do we say to these patients when they ask us this question? So we really wanted to fill this gap where we really do not know of why is the case that 5% to 10% of MS patients will be significantly disabled by their disease compared to the majority, the 95% of patients who can live with disease with relatively preserved functioning during the rest of their life. And really that's something that we need to answer. So how the whole idea of the CASA-MS study happened and the collaboration of the study actually happened, and this is because of this wonderful lady here, Mary Jo Montani, who probably you have known and been friends with her before. Mary Jo has been a long-time Boston home resident that she unfortunately passed away in 2019. And Mary Jo has a brother, Larry Montani, who lives very wide to Buffalo in a town called Lewiston. And Larry is part of one of the most important aspects of our research center, and that's the BNAC Advisory Council. Why do we have an advisory council in BNAC that is consisted of MS patients or from families of MS patients is because we as researchers, we as academia, we really do not want to lose track of what is important when we do some research. We can go on and on doing research in academia, but really we need to have someone that will always remind us why are we doing this and who do we do it for. And therefore we have a council of MS patients that always guide us to what is important to them and not to lose track in terms of what we're researching. And in that council, Larry actually used the opportunity of his sister's events that he wanted to somehow have a meaningful impact and come up with an idea to join the Boston Home in terms of learning about the severely affected multiple sclerosis, something that after we looked at the literature, nobody else has looked at over 30, 40 years before. So this is mainly patient-directed research, and it's not an idea that came from us, but actually came from the patients and their families. And that's how the relationship for this study started, this joint collaboration between the Buffalo Neuroimaging Analysis Center and the Boston Home. And we wanted somehow embody that forever, this relationship, and we used two pictures that were done. One was by the Mary Jo, and that's the sunset, and then we have another picture of the house of Rhonda that drew together with Mary Jo, and we kind of collaged them together into creating this logo of CASA-MS, and that's how this logo of a house with the sunset behind is just the friendship and relationship between Rhonda and Mary Jo, and I think that represents also the friendship and relationship that we have between Buffalo Neuroimaging Analysis Center and the Boston Home. So that being said, now I would just shortly explain the rationale, which I already mentioned. It's because most people with MS are faced with the possibility of advanced progression. Families really, and the patients themselves really want to understand and plan for the future that they need to face. So we, as clinicians, really need somehow to know and learn how can we actually educate them and provide them with some real strong evidence of where their health and their disability are heading going forward. So now we have produced a video together with the Boston Home of a video about the CASA-MS study, which we can definitely play here. And I can make it even bigger for this particular.
As a patient with advanced progressive MS, I can say that dealing with this disease can sometimes feel like being stuck in a slow-motion car wreck.
BNEC research provides hope to MS patients, especially people with secondary progressive MS that have not had a lot of research done.
There are several types of multiple sclerosis. So far, little research has been done to ascertain the perception of severely affected patients with MS, defined usually as those who have advanced disability with score of 8 or more on Expanded Disability Status Scale, or EDSS.
Multiple sclerosis is no joke, you know, and no, I've had it for 18 years. I didn't really joke around with it, but I've learned, you know, I've gone from using a cane, and then that progressed to a chair.
I've lived with MS for over 40 years, and it may sound a little strange to say this, but in many regards, I've been pretty lucky, and that my particular course of MS has been rather stable, and I was able to still have a career and enjoy many things in life. But there is a smaller group of patients that have lost so much of their lives, and it's greatly impacted their caretakers as well.
Fully characterizing severe multiple sclerosis is elusive at this time. No imaging, cognitive, clinical, or other biomarkers are established to fully characterize this type of multiple sclerosis.
The EDSS defines disability entirely by restricted movement. Yet a person is much more than just physical movement. As exemplified by the now famous Stephen Hawking story, some people that are very physically restricted may have normal or only mildly affected functioning of emotions and cognition.
We found a partner in Boston Home, a premier resident facility located in Boston, which hosts about 90 patients with multiple sclerosis. Together with their help, we are going to study this population of severe MS patients and compare them to another population who is located here in Buffalo but did not advance yet to this progression of the disease.
So the Boston Home's mission is to provide outstanding care for adults with multiple sclerosis and other neurological disorders.
We know that at the Boston Home, these patients are receiving exceptional care.
They do such good work. And for me, they're a lifesaver. They gave me my life back. So I can't put a price on that.
What the Boston Home has done for Edna and myself was give us a new perspective on how we can still manage our life together in a way that is conducive to her adapting to the current situation.
This isn't your traditional nursing facility. Our staff are highly skilled, they're dedicated, and truly we become family with our residents and their families. The relationships that are built here are truly incredible.
CASA-MS is an abbreviation for a study called Comprehensive Assessment of Severely Affected Patients with Multiple Sclerosis. It clicked just like this to start this project, and it was natural to design such a study.
Members of the BNAC Advisory Council are individuals with MS or close family members of those with MS. We're proud to be partnered with the BNAC research team in their translational research in MS.
The CASA-MS study is the first study that I'm aware of that is looking at treatment for very severely affected people with progressive MS.
This study will target progressive MS patients with advanced disease that usually are not included in any research project.
And one thing we really want to look at in this study is to understand how enriching environments like the Boston Home can potentially help the brain to be adaptive, how it can rewire itself and work to work around the disease.
The CASA-MS study will be conducted in two separate phases. The first phase of the study will include 60 severely affected MS patients that have previously had an MRI scan. For that, we will have to adapt our wide array of tests in order to better assess their cognitive and physical disabilities. The second phase of the study will additionally perform an MRI scan 12 to 24 months after the initial scan. This will allow us to have both cross-sectional and longitudinal analysis in terms of the relationship between the structural and functional changes in these severely affected multiple sclerosis patients.
This CASA-MS study is just going to give us knowledge from a population that's been so dismally ignored since I was first diagnosed in 1988. CASA-MS is saying, these are real people, you could be one of them, but we're here to help.
I believe the BNAC and its collaborators are really uniquely positioned to do this type of study. We have incredible clinicians, we have people with extensive neuropsychological expertise. This investigation really deserves that kind of multidisciplinary assessment. We need to understand all the aspects of severe MS so that we can understand how it progresses, how we can treat it, and how we can predict what's going to happen in these people.
I'm really urging you to support this study because it does represent unmet needs in identifying the causes and also possible treatments for MS.
Please join me and members of the BNAC Advisory Council in support of CASA-MS. You'll help to set standards of care for those most severely affected by MS. Your support matters. Every dollar counts. Help us make a difference and win this fight against MS.
As a family, Tracy and I and our 3 daughters are very interested in advancing the understanding of progressive MS.
We're pleased to have been able to help the CASA-MS study research get started and hope others will join us.
Without your help, we cannot complete this study.
Now I'm going to hand over the mic to Taylor, and after the whole presentation, I'll be back to answer all of your questions, and we have booked significant time to answer any of your questions.
Thank you, Dejan. All right, hi guys. So, as the video had said,
We are taking 60 patients from the Boston home who had had a previous MRI, and we are matching you with 60 patients from the Jacobs Center in Buffalo, New York. And how are we doing that, you ask? Well, we match you by age, gender, and the amount of time that you've been diagnosed with MS. All right, so some notable study procedures for the CASA-MS study. As you know, some of you had your blood drawn. Ooh, needles, right? So what we're going to do with that blood is we're going to do a full genomic testing with it, because there's some current literature that contributes the severity of MS to genetic loci that influences the progression of disability. And through that, we're also going to be looking at serum neurofilament light chain analysis, as well as glial fibrillary acidic protein analysis as well. We also have some neuropsychological examination going on. I know I have seen some of you this week. I know some of you have also seen Zach this week. So we had some learning and episodic memory. Oh, we skipped a slide. So we started with some information processing speed, which was the symbol digit modalities test. And that picture is displayed on the right on this slide. You can see a bunch of symbols and no numbers. So we had asked you to match some symbols with some numbers if you had done the testing with us this week or previously. And then we had also developed a new test that was better suited for processing speed, in which Zach is going to tell you a little bit about.
Hey everybody, nice to see some familiar faces. Especially anybody I've worked with. Thank you so much for being so generous with your time over these last few visits to Boston. It's been a pleasure getting to know and work with some of you. So, as Taylor was mentioning, our neuropsych evaluations involve information processing speed, among other things. And the reason we are in particular highlighting information processing speed here is because among all of the different sort of facets or domains of cognition, information processing speed is probably one of the most sensitive measures we have in people with MS. It seems to be one of the first things that can start to deviate from healthier patients. And it's also, it even differentiates MS patients who are relapsing from ones who are relatively stable in comparison. So it is really sort of the gold standard measure we have. And that SDMT that Taylor pointed to, like I said, this has become really the gold standard. If you can only use one test, this is the one. The issue is it requires sufficient vision to do so. And as many of you I'm sure are aware, optic neuritis can be a pretty impactful issue in MS. Your vision can be disrupted. And as a result, much like this study as a whole, you wind up with patients who just aren't evaluated or aren't appreciated because we simply don't have the wherewithal to test them appropriately. So one of the things we've sort of endeavored to do with this new test, ATOPS, is to take vision out of the equation, because hearing tends to be better preserved, and also there's things we can do in terms of hearing aids that allow us to sort of still meet you where you are and test people appropriately. So any of you who have taken ATOPS, you've seen we tried to keep it relatively simple. We give you some different tasks, and all it requires is a yes/no response. So we're hoping that we're sort of meeting you, even if you have trouble with speech, that this is still something we're able to measure, and we've actually moved on beyond sort of the very beta version that many of you have taken at this point. We're in the process of developing a full-fledged app. So it's just one new way that we hope to be able to evaluate people with MS and make sure that regardless of where you are in terms of vision, you're being evaluated appropriately. So beyond just information processing speed, there are other aspects of cognition we're interested in. So as Taylor mentioned earlier, one of the things that we can see that tends to go wrong is learning and episodic memory. And there's sort of two domains of that. There's visual memory and verbal memory. And we know that these are represented in different areas of the brain, so it's worth testing both. So up on the screen here, you see sort of figures that might look familiar if you've taken the BVMT before. And that's where we've asked you to sort of memorize these and reproduce them. That tends to be one of the other very sensitive measures we have in MS. And then there's also the CVLT, the California Verbal Learning Test. And that tests your verbal memory, and that's when I read that never-ending list of words to you and ask you to repeat them. And I know after 5 times, I'm sure you were sick and tired of it. Imagine me doing that 60 times with different patients. I dream of those words sometimes, but it's another important aspect of cognition that we're measuring. And again, appreciate you sticking with us as I read those words over and over and over. Beyond that, we also look at things like verbal fluency. So how well do you access all of the words you've learned across your life when we've given you letters like C, F, like how many words can you think of that begin with those letters? That's another aspect of cognition that tends to be impaired in people with MS. And last, we look for things like can you still find the names for different items or objects with this naming task? And as I flip through the picture book and ask you what those things were called. And that's just one other aspect of cognition we're able to look at. So beyond just cognition, we also look at some of the motor components of MS. Of course, especially here in Boston, we're trying to meet you where you're at. We know most of you don't have particular function in your legs, but we still want to be able to evaluate where are you at in terms of your hand dexterity, because of course that's so important. Even being able to, use a remote, read a book, pick up a fork or a spoon, all these things are really important. So one of the things we do, we look at fine motor skill using that peg test where I have you pick up those 9 pegs and put them in those holes. And then we also look at coarse motor skills. So it doesn't require as much dexterity. It involves a lot of your shoulder as well. And that just gives us one other dimension by which we can sort of figure out exactly what are your abilities, where are you struggling, and just get a better sense of how the MS is affecting each and every one of you. So with all of that in mind, I'd like to just discuss some of the directions we're hoping to take this and really answer sort of why we're doing what we're doing and what might come next. So the immediate goals, especially with this trip, has been to conclude the matching and recruitment of patients from both Buffalo and Boston. That's why we've been working so hard to get so many of you through this past week, and I'll be working with some of you this afternoon and also tomorrow as well. To analyze this data, we're going to be looking at things such as, was there a diagnosis delay? I know some of you have told me how you had symptoms perhaps 20 years before you were formally diagnosed. And we're hoping to understand perhaps, does that delay in diagnosis and perhaps initiating treatment maybe what contributed to where you are now as compared to somebody who was able to get diagnosed really quickly. Further, we want to look at, do different treatments perhaps impact the course that we've seen? Somebody who was put on one medication versus another, is that influencing where we are today? We also want to just get a better sense of what do your brains actually look like on that MRI scan? Is there anything different in terms of atrophy, lesion load? Do your lesions change differently? For example, lesions can perhaps advance and we see a true loss of the brain tissue that was once lesion, or is it perhaps some degree of recovery where there's some partial remyelination happening? And does that inform where you are today? And there's even more advanced measures we can look at. We can get a sense of what's called myelin integrity, which it's not even like a macro level change, but it's rather how much myelin, that insulation around your nerves is still left. And we're also going to look at things such as blood flow in the brain. So there's lots of different things we can look at with these new and emerging MRI measures we have available, and hopefully we'll be able to use that to answer some questions to, again, differentiate all of you from the patients in Buffalo and to get a better sense of maybe what predicts these different courses. And we'll also be looking at your disease duration. So some of you who've had the disease for less than 15 years and you are now in a chair, that's considered a more rapid or aggressive disease course. And hopefully we'll be able to understand perhaps what contributes to these more rapid courses as compared to somebody who just progressed over a period of 20 or 30 years. In addition to all of that, we're going to be exploring the relationships of some of these newer MRI measures with cognitive and physical disability. That's why we've done this very comprehensive assessment with you all, is now we want to try and see if what we see on MRI correlates or matches what we're seeing in terms of your physical and or cognitive disabilities. For example, we know that different portions of the brain, be it size-wise or their connection to other brain regions, tend to correlate with what we see on cognitive disability. But also, it's usually not perfect, and we're in the process of trying to figure out better ways to see if what we see on MRI really does explain what we're seeing in the clinic. We're also going to be exploring the relationship of these MRI measures to things such as your blood biomarkers, so such as those like glial fibrillary acidic protein, neurofilament light chain, maybe genetic markers. Is there any correlation between those? And another thing we'd like to look at, as actually one of my mentors, Mike Dwyer, mentioned on that video from earlier, what is the potential impact of the Boston home? An enriching facility where you're with, you have many social opportunities, you have trained healthcare workers. How is that influencing perhaps your disease course? And really more importantly, the patient-reported outcomes. Because at the end of the day, what matters is your perception of where you're at, because you're the ones living with your disease. And how has the Boston home perhaps influenced, how do you feel about where you're at now? And in terms of the mid to longer term goals, as was mentioned earlier, this study will be continuing. We'll be probably following up with you all in 3 to 4 years, and we're going to try and get a sense of what's changed in that meantime. So this visit here serves as an important baseline. And we'd like to see what changes on MRI, what changes in terms of your clinical or cognitive ability or disability, what's changing in terms of your blood. And this is really going to allow us to determine what is the rate at which things change, and perhaps what's predicting where we go from here. Again, an incredibly understudied proportion of MS patients up till this point, and we're hoping we can really help you all better understand what lies ahead, and everybody like you, because it's truly a tragedy that patients like yourselves have been excluded from research up to this point. And we're really hoping to get a better sense of what predicts this course, what lies ahead, and what maybe we can do to help. And after all that, just want to say thank you to everybody and invite Dan back up onto the stage.
So this picture is the first visit of our PIs, primary investigators at the Boston home, and this even happened before COVID. And as you can see, Larry is here, our professors are here, and really a huge thanks to Christine, to Jessica, to Alex, to David, to really make this happen, and we'll be able to come here for 3 or 4 times to do this study. And first of all, nothing of this would have been possible if you didn't said yes to joining the study, and actually the reason why we're here. And I'm really grateful for everyone who's joined the study and said yes to participate, and we learned something out of it. So now I left a big chunk of my time for the most important aspect, and that's the questions and answers. And we'll start with the first question if anyone has one, and I'm happy to answer. Go ahead.
This question will affect everybody. After all your hard work and efforts and calculations, will you ever, or will there ever be, as much as we're looking for a cure, will there ever know whether it be genetics, or is it just the cards were dealt that we got this disease?
Yes. So in the past, let's say 5 to 10 years, we have really learned so much about it, and I can only expect exponentially to learn more about it. So for example, just in this April at the American Academy of Neurology, for the first time they showed a particular gene that is associated with the severity of the disease. That means a person who has this gene might be more susceptible to progress to so-called aggressive multiple sclerosis. We didn't know that before April when it was presented. So how can we learn that? And we are trying to replicate a similar analysis with the blood draws that we're doing. So how can we use that is that when a young patient comes to our clinic, a young lady, and we draw blood when she's 25 years old and first time having vision problems and see that she has that gene, which is relatively rare, then we can really work towards explaining to her that this might be a consequence and going forward have to deal with significant disability. And then we really make big decisions in terms of therapy and how much of a risk we are taking with this lady. There are certain medications with multiple sclerosis that are really immunosuppressive and they put you at risk for many infections and other side effects, but they're also very powerful and they can shut down the inflammation and the progression right away. So this particular lady, I would not go with a therapy that I would wait to fail and then I would go to another therapy and then another fail, because every time a therapy fails and there's a new attack, we're losing something that we cannot recover later. So it's very important. There's this saying, hit hard at the beginning, and if it really works and we put the disease into relatively stable rate, then we can scale down and put her on a more safer therapy where we can maintain her for safety reasons. So this has been a revolution in terms of how do we approach the patients from a treatment perspective and how we can guide them forward on what they should expect. In terms of cure, I have to say that in the next 10 to 15 years, unfortunately, I'm as realistic as possible with this, is that we probably will not be there for a final cure. However, we're learning more and more on this disease, what we call MS right now, is basically a conglomerate or a group of different types of MS, and maybe that's the reason why can it be explained. Over the past 5 to 10 years, we're starting to parse out different diseases with different mechanisms, with different medications that work on them out of this what we call MS. So now we learned that something that was called MS 10 years ago, today it's called with a different disease that has a particular different type of medication, and they respond much better than if we put on the particular MS medication. Tomorrow we can learn that maybe 30% of what we call today MS patients are the ones who get infected with the Epstein-Barr virus and have caused the autoimmune disease due to the virus, and this 30% may be responsive more to antiviral, antibiotic type of therapy versus the immunosuppressive therapy. But really, we really need to first determine what's the mechanism of their disease, how do they got the disease, and then we can actually develop cures before that. Before we know what we target, we really cannot target it before that.
Thank you.
Great question.
Any other questions? Go ahead.
I have a question that's kind of awful. Out of the realm of
No problem.
out of this particular study, I'm asking if you guys work with the Moreno Center in Boston, which is with the Mass General Hospital.
No, we don't have a currently ongoing study with the Moreno Center. Our closest collaborators are the Brigham and Women. That's our biggest collaborators. And going forward in that second visit, where we would like to have a follow-up at 3 to 4 months, we were planning to have an MRI scan using the facilities of Brigham and Women with the collaboration we have with the people there.
Okay, thank you.
Any other questions? Yes?
Does the power of the Tesla machine, the MRI machine, does that make a difference from one scan to the other?
It definitely does. So it does not go forever in terms of power. So currently in the market, there are several strengths of MRI machines, starting from 1.5 Tesla, which was very common, that got replaced by the 3 Tesla MRI machines. And since 5 years ago, FDA has approved a 7 Tesla MRI machine that is really available only in a couple US centers. I know that Mass General has one, I know Vanderbilt has one, etc. But the images itself are clearer as you go increase with the Tesla of the scanner. So if you have a 0.5 Tesla scanner, those open ones that you can just freely move inside, the images are very grainy and we cannot really differentiate what is really an affected or non-affected brain. But if you go up to a new 3 Tesla machine, we can really clearly see where is the lesion, what's the lesion around, which tracts are really affected by that lesion, how much myelin is being stripped off the axons on the 3 Tesla scanner. On a 7 Tesla scanner, which is now research, we can even look at micro levels and we can determine what are the molecules within the lesion, how does the lesion changes the molecules, what's the amount of axons in that particular lesion. But unfortunately, 7 Tesla is currently not being used for clinical routine care of MS patients, even though it's being FDA approved. So if you're going to have an MRI scan in the future, I definitely would say try to have at least a 3 Tesla MRI scanner. Going forward, that would be to get the best buck for the value for the buck in terms of how much we can see from the MRI and how much we lose by not having a 7 Tesla. Yes?
I was diagnosed a couple of years ago, and I've been symptom-free after that. I mean, totally symptom-free.
Okay, so you have progressed during the first period of the disease, and then it has been symptom-free period afterwards?
I was symptom-free real soon after I was diagnosed.
And for a long period of time, you've been symptom-free until at some point you started to deteriorate, or?
No deterioration at all.
I see. So there are types of the disease which we call clinically isolated syndrome, or where patients would have a significant attack at the beginning, and that significant attack will cause certain amount of disability that not necessarily everyone will fully bounce back from it. And some of these patients, after this attack, they end up not having any attacks for the rest of their life. So we call these patients as clinically isolated syndrome. And their disability, it really depends how much of a damage has occurred on their first attack. So we have patients where I know a lady, 35-year-old lady that had an attack, one attack only. It was in her spinal cord and she was not able to walk. She did somehow recover to use a walker. She never had an attack in the next 20 years and she has been fully stable, but still has a residue of that first attack that has occurred. And that term, we call it clinically isolated syndrome because we don't have sufficient information to call her multiple sclerosis. And we still treat them with the same medication as we treat MS patients, this clinically isolated syndrome. So as I said, maybe we need to parse out a little bit better. What does it mean to have one attack, big one at the beginning and being stable later? How do we approach the treatment for that particular person versus how do we approach a treatment that slowly progresses and worsens over time? And really, we do not have any guidelines on how do we approach this. We only have these set guidelines for MS patients, and I am fully aware that we cannot apply the same guidelines to every single person out there with multiple sclerosis. Thank you for the question. Go ahead.
So I don't walk well. But other than that, I'm always normal.
That's great to hear. Please stay that way.
I think, Joey, did you have a question?
No, I answered. Yes, answered.
Okay.
Thank you, sir.
Any other questions? Yes.
I don't mind to
Go ahead.
Yes. Do you have any knowledge of myelin repair and how close they are to repairing the myelin?
Yes. So there are several clinical trials that are ongoing in terms of myelin repair or myelin salvage therapy. Unfortunately, the first several trials that we have had over the past 5-10 years were negative in terms of we're able to accomplish myelin repair. However, we're learning more and more that there are certain inhibitors in the brain that prevent the myelin to replenish. And what we need to do going forward is to attack those inhibitors and remove them out of the brain, so to let the normal process of remyelination occur. Before we do that, we really have to develop techniques. How do we measure the amount of myelin? Because if we cannot measure how much myelin there is now after giving a therapy, we cannot know how much myelin has actually improved or not improved. So in my personal view, within 5 to 10 years, we're going to have fully remyelinating trials, ongoing phase 3 trials, and we're going to use a special technique of imaging to determine the amount of myelin that is called PET, or positron emission tomography. And this is where we inject patients with a radio tracer that emits energy, and the amount of energy emitted is the amount of how much myelin there will be in the brain. And by that way, we can measure if these molecules that are inhibiting remyelination are affecting the remyelination. So we are very close. We are just dealing with, first, how do we measure the myelin, and later, is the molecules that we think we're going to help, are they really helping the remyelination? So within 5 to 10 years, I expect trials like that to be occurring.
Thank you very much.
Christine?
Hi, thank you. This is a wonderful presentation. Do you have any information on research around stem cell?
Yes. So stem cell research really had its highs in the later 2010s, and we really have very clear data that stem cell therapy is very beneficial for early multiple sclerosis that are very active and aggressive MS patients. These are MS patients who, despite very strong therapies like the Tysabri infusion, like ocrelizumab infusion, they still keep on having gadolinium-enhancing lesions and still have relapses. We show that stem cell therapy really shuts down this inflammation. And there are several trials that they show that really this marker, neurofilament light chain, which, just to explain what does it mean, that's a building block of our neurons. So imagine like being the skeleton, these steel bars of a building, and that the building is the neuron, that's the neurofilament. As this neuron is being destroyed, these planks are being distributed around the body and into our bloodstream, that's the neurofilament. And now, for the first time in the past 2 or 3 years, we can draw a simple of blood, and we can measure how many of neurons in the brain are actually being disentangled and parsed out into the building blocks of neurofilament. And we see that stem cell therapy brings the neurofilament levels in the bloodstream, or how many neurons are being destroyed, back to what is expected in healthy individuals that are aging. But this is mostly working in patients who are 55 and younger and who are very aggressive with MS therapy. It doesn't have the same benefit in so-called progressive multiple sclerosis and secondary progressive multiple sclerosis.
Thank you.
Alex?
Yes, thank you. Just some of the folks who have participated in the study so far have been asking if they, at what point they might be able to connect with their Buffalo twins, quote unquote.
Yes.
Could you just give us a brief timeline of how the data collection is going and when we might be able to allow that connection to happen?
Yes, actually, every single MS patient that is part of our Buffalo site continuously asks about their MS twin at Boston.
Yeah, it's the same on each side.
So I actually have received several letters from our Buffalo patients that they want to forward to their MS twin in Boston.
Wonderful.
And we definitely would like to do that the other way around as well. From a perspective of the study, once we complete with the recruitment, which we expect to be this week, and we go back to Buffalo and match you all to your MS twins, at that point, we're fairly confident of unblinding, so-called, the study, where we can actually put together these two twins between the Boston home and the Buffalo patient and actually establish this communication. From point of letters or contacts, I'm more than happy to facilitate that interaction, let's say starting September after we unblind the study.
Exciting.
Very cool.
Thank you.
You had another question?
I do. That radiologic study in the PET scan,
Mm-hmm.
I was in that. And that's why I said something about the Marino Center. They were studying multiple sclerosis and ALS.
ALS?
Yeah, both of them, because the father, Charcot, is the father of MS and ALS.
And of psychology as well.
Yeah.
Psychiatry.
Yeah, all of these. And so I did that.
Yes, I am aware of a phase 2 trial for using PET imaging, this radio tracer imaging in ALS. I'm also aware of a potentially an MS trial going forward in the future that will use PET scan as part of their imaging.
Yeah, but I wanted to see if you were part of the Marino Center.
No, not particularly familiar with the name, but I know of the literature.
They're right associated with Mass General.
Any other questions? Excellent. Well, do you have a question? No? Oh, please.
There's a new medication I may go on called Mavenclad. Where you give 10 pills first year, 10 pills the second year, and then you're basically done with your MS meds. What do you think of a drug like that?
So Mavenclad, or the generic name is called Cladribine, has been FDA approved in 2019 for treatment of relapsing, remitting, and active secondary progressive MS. Unfortunately, FDA did not approve this medication for treatment of secondary progressive non-active multiple sclerosis. The medication itself has very good data, long-term data. However, the medication works the best when it's given to patients with aggressive multiple sclerosis that have previously failed 2 particular therapies for MS, and they're still active, meaning that they have still relapses and new lesions to the brain. So I personally would prescribe this medication to a young, fairly active MS patient that has failed multiple medications before that. However, in a patient that has not had a relapse in many years until we got to that point, then I don't expect that medication to work as good as would work in this active gentleman.
Thank you.
There is a medication in 2018. The FDA approved the first ever medication that had positive data in secondary progressive MS, and this is called Siponimod or Mayzent. This is a very similar medication to an older medication that's called Gilenium, that maybe some of you may have been on it. But with this medication, the trials show that we have approximately 20 to 30% decrease in the progression rate in secondary progressive MS patient. And what is even more important, that this medication decreases the amount of cognitive decline in secondary progressive MS patient. But this is an educational program, so I don't want to go into what your neurologist should be able to do.
Why not?
Thank you very much. Once again, nothing of this would have been possible if you have not been willing to participate in this study and really encourage us to do studies like this. If anything, this study came from a personal relationship between Larry Montani and Mary Jo, and we'd like to do studies that are important for MS patients, and they are going to be contributing towards their life and well-being.
Thank you, everybody.
Thank you.